Dr. Fauci, nice to see you.
Good to see you.
Dr. Fauci, what's a pandemic?
A pandemic is an outbreak of an infectious disease that is widely spread. You know, the people, when you want to distinguish between a pandemic and an epidemic, you can have an epidemic in a city or an epidemic in a state or even in a country. When you have a pandemic, it's just essentially broadly spread out throughout the globe.
Out of control?
Yeah, I think by definition, when you say pandemic, it is out of control. Otherwise, it wouldn't be a pandemic.
Historically, when have we had pandemics?
Oh my goodness, it goes back to recorded history. I mean, there were outbreaks of diseases that were called the Great Plague of Athens. We didn't know what it was. It was just an outbreak of a disease. And when you first started to understand the germ theory, for example, the pandemic of 1918 is one of the most historically devastating pandemics of influenza. 50 to 100 million people were killed. There was measles pandemics that we had throughout Europe. The bubonic plague, Pasteurella pestis, was another pandemic since it essentially spread throughout the world.
You know, it seems to me that when you talk about pandemics, is that you're talking about spreading, obviously, and that today with everyone traveling so much, I could catch something or get something in Thailand on a bus and be on a plane the next day to Beijing, spend a couple days, and come here to the United States and spend a couple days. It seems to me that the capability of spreading it is with transportation as it is so much higher now. But do we have them so much?
Well, you are absolutely correct. If you want to pick out one factor that essentially leads to the rapid spread of an infection that would make it a pandemic. I mean, you could have a little outbreak somewhere and stay confined if we were in an era centuries ago where there wasn't that much travel or travel was so difficult. Right now, if you look at the plane schedules, we're 18 to 20 hours away from anywhere in the world. I mean, it's just anywhere you want to go. You want to go to China, it's an 18-hour trip that goes all the way around. You want to come back, it's the same thing. So when you have particularly a respiratory-borne illness, which is the thing we worry about the most because that's what spreads easily and rapidly, and it is in confined places when people are in planes, when people are in schools, when people are at work. Travel itself is the thing that really is the showstopper when it comes to pandemics.
What keeps you awake at night, if anything?
Well, the thing that I worry about most as an infectious disease person is indeed a respiratory-borne virus that spreads easily, that has a high degree of what we call morbidity, making people sick, and mortality, can actually kill them. The one that always comes to mind is influenza, because influenza is a well-known human pathogen that spreads easily by respiratory. So I worry about the next influenza pandemic or a pandemic of a respiratory disease. Remember, we had SARS that was fortunate for us that there was a big outbreak, but then because of public health measures, we were able to contain it. But sometimes you can't contain these outbreaks very well purely by public health measures. And that's the reason why we need to continue to sharpen our capabilities of developing vaccines rapidly in response to pandemics.
All right, well, you've got the problem, though. We've got the fact that it spreads, the respiratory spreading and how easy it is to spread, and you've got the transportation that we're 18 hours away from every place. What about the cooperation between nations? I mean, we might have a nation like the United States. I hope that we're ready and prepared for things as much as we can be, but some nations, do all nations, are they ready?
Well, to a greater or lesser degree, I would say. There are some that are more capable of responding and having surveillance to alert the rest of the world that there may be something different going on in their country. And then there has been the problem over the years, intermittently, with a lack of good transparency, where a country was somewhat reluctant to let everybody know that there was something different going on with an outbreak for a variety of reasons. The most important one is economic. They don't want there to be essentially an ostracizing of a country with tourism and economic impact. But today in 2018, it's much better with regard to transparency. What we've established now, we the global community, is the Global Health Security Agenda, which means an interdigitation and connectivity with most of the countries in the world to allow them to be able to detect and communicate as quickly as possible, so that when something occurs in country X, there isn't a 2 or 3 month delay before people start to realize that we're dealing with something different. And that is something that has, over the last several years, it started off, I would say about 5 or 6 years ago, where we developed this global health security agenda.
Well, if you have an influenza, first of all, to have a vaccine, it would be the first step. That costs money. And then something like maybe Tamiflu to try to treat it or minimize the impact, that costs money too. What about some countries, like let's take some of the poorer countries in Africa. You get on an airplane and you go there and you spread something, and now what? Do they have the supply, the Tamiflu supply? Do they have the medical resources?
Short answer is no, they don't. And that's one of the things we really need to be concerned about, and one of the reasons why we are trying to develop what's called a universal influenza vaccine, namely a vaccine that is effective against any changing or drifting strain of influenza, as well as any major change which would lead to a pandemic. Because right now, we're in this somewhat compromised situation where we have to chase after pandemics. We react to them as opposed to preemptively being prepared for them. And the reason for that is that influenza particularly, which is the one we worry about the most, even normally from season to season, tends to drift or change, so that the vaccine that is available this year for this strain, next year the strain may change just enough to make it necessitating to get a new vaccine. Now, we do that in the developed world. We get a new vaccine every year. It's costly, but we do it. In a developing country that has so many other health problems, they almost can't afford to do that from year to year. Now, if a pandemic comes, they're going to be in a lot of trouble because they don't have the resources. I mean, the capacity to make vaccine for everyone in the world who would need it with an outbreak is just not there, because you have to rush to do it to catch up and respond. If you had a vaccine that you could stockpile, the way you stockpile measles vaccine, polio vaccine, smallpox vaccine, which thankfully we don't even need anymore, then you're way ahead of the game, particularly in the developing countries who would really have a problem with mobilizing immediately to respond to a pandemic.
All right, those underdeveloped or poorer nations, let's take Africa as an example. What can the United States do, or what should the world community do to help them, and how serious a risk is it for them?
Well, again, it depends on what you're talking about. If you're talking about influenza and there is a major outbreak, that's going to be a problem. There's not much that you can do, except what we do is that we do share supplies. Like when we were preparing for a pandemic, or had a pandemic, the 2009 H1N1 pandemic, there was Tamiflu and other antivirals were made, but there is an agreement to the best of our capability to share some of that, not only the United States, but other developed countries, to share some of those supplies to the developing world.
Are all nations willing to take vaccines? I mean, I know there's been controversy with certain vaccines. That's the first question. The second question is that the flu vaccine, I took the flu shot last year. I got the flu, and I was told it was, 40% effective or something, and I fell on the bad side of the equation.
Well, yes, that's again getting back to the issue that we need to do better with influenza vaccines, which is the reason why we are working very hard now in a very concerted effort to develop this universal vaccine. And by universal, it means that it is against virtually all the strains. Now, if you look at how effective flu vaccine now, I must start off by saying it is always better to have some degree of protection than no protection at all. So if a vaccine is 40 to 50% effective, or even 30% effective, it's better than not getting vaccinated at all. But we shouldn't be accepting a 30 to 40 to 50% as the end game. We should take the vaccine because it's better than nothing, but we need to push the envelope and get influenza vaccines that are in the 90+% effective.
How far are we from a universal vaccine?
I think it's years, Greta. I don't think that this is something that we're going to say we're going to have next year or the year after, because there are a lot of scientific questions that need to get answered about how you can actually get the body to make a response against something it doesn't naturally make a good response against, because the body easily makes a good immune response against that part of the influenza that changes from year to year. So if you hit it right with the right call on a vaccine, you're good for that year. What the body doesn't do very well is to make a response against the part of the influenza that doesn't change from year to year. So if we could figure out a way to induce the body to make a response against that constant part of the virus, we'd be much closer to the issue of a universal flu vaccine.
Now, we've been talking about pandemics where people spread it or catch it. Do you have any concern or is there any risk that this could be weaponized? That any rogue nation or rogue group would weaponize with viruses?
Well, there certainly is a risk, and that's the reason why back in 2001, after 9/11, when we had the anthrax attacks, even though that turned out to be a homegrown terrorist, that we put an extraordinary amount of money, investment, in developing a biodefense effort, which is very closely allied with what we do against naturally occurring microbes. But the indirect answer to your question, there certainly is a risk, which we have to be prepared for, that certain microbes can be weaponized.
Are we, meaning the United States, more prepared for that? What about other nations? Are they looking out? Because there are a lot of rogue groups out there. It's not just it's not just the United States that needs to fear this.
Well, the world does fear it, but as usual, when it comes to biomedical research, the world looks to the United States for leadership and investment. When you look at the amount of money that's invested in the kinds of research that's necessary not only to combat against naturally occurring infections, but that necessary for deliberately propagated infections, the United States overwhelmingly is the country that is making the most investment. Take a look at what happened just recently with Ebola in West Africa. When you look at the amount of resources that were put into Ebola to help the West African countries of Guinea, Sierra Leone, and Liberia, although other countries did volunteer and did well, when you're talking about resources, clearly the leading country was the United States.
What was sort of interesting with I went to Liberia a couple times and covered very closely the Ebola. There was a profound response. You had the Doctors Without Borders were taking care of two countries. You've got the American medical people. Samaritan's Purse was there in Liberia. Are you surprised that was contained? A lot of people did die, but there was a lot of fear, even fear here in the United States. You treated someone, I think, here.
Two people, right? Yes, right here.
Are you surprised that it was that the Ebola virus was contained, and is it contained?
No, well, it is contained. There's no. Ebola is one of those diseases where you have an outbreak and then it goes away, and that's it. It's done, and it's an animal reservoir, and that's why you keep coming up with these outbreaks. Sometimes they're mini outbreaks. It was first discovered in 1976, and there were 24 outbreaks ranging from 2 or 3 cases to a couple of hundred cases, usually in rural areas that were not explosive. The situation that was different in 2013, 14, and 15 was that it was now in 3 countries with porous borders, with high populations, and it got into the cities. It got into Monrovia, into Conakry, into Freetown. That's when you had the 28,000 cases and 11,000 deaths. I'm not surprised, Greta, that it was contained, because Ebola is one of those infections that with good, strict public health practices, you can contain it. And the big 3 was identification, isolation, and contact tracing. And once the countries got used to that, that's when the outbreak essentially disappeared.
But you've got a situation like in Liberia, where, with Ebola, and correct me if I'm wrong, is you catch it by touching people, bodily fluids, and whether you bathe them after they die or try to care for them, is that you really have to sort of change almost a culture. You got to stop hugging a little bit. You got to stop shaking hands so much.
It wasn't easy.
It wasn't easy.
It was not easy, but it was accomplished, and it was accomplished by a good collaboration. The countries themselves deserve the credit for making the change, because, as you mentioned correctly, the tradition of how you handle ill family members, how you handle expired family members, the tradition, which is, part of the beautiful part of society is the affection for your family. And when the family dies, you clean the body and you hug and you kiss and you say goodbye. That was the worst possible thing that you could do with Ebola, because Ebola, in contrast to influenza, is not spread merely by respiratory, talking, aerosol. You can give it. You have to directly get exposed to the contaminated bodily fluids of a very sick person. So if someone is Ebola and isn't very sick and is not vomiting or having diarrhea or bleeding, that person is not going to spread Ebola. It's the physicians, the nurses, the healthcare providers, the family members, and the morticians who were at risk. It was a very interesting situation in West Africa. There were over 800 healthcare providers that got infected taking care of people who with Ebola, and 500 of them died. That was probably the worst devastation of healthcare providers in a given disease than we've ever recorded.
Well, Dr. Brantley, who was with Samaritan's Purse, got an antidote of some kind, but
Right.
but it's not stockpiled.
No.
And so, if Ebola does rear its ugly head again, in which, from your description that it probably will again, we're not ready. Africa's not ready for it.
Well, I can tell you that we're much more ready than one might think, because one of the reasons why Liberia, Sierra Leone, and Guinea did not do as well as some of the other countries like Nigeria and Mali is because they had never had any experience with Ebola. This was the first time there had ever been Ebola in that part of West Africa. Right now, when we went in, when Médecins Sans Frontières went in, when the CDC went in, when the Chinese, the Brits, there were a lot of groups that went in there, they not only trained the local population, but they left some sustainable infrastructure. Because when my team went to Liberia, and we focused on Liberia, we went in and not only got involved in training the individuals how to respond, but we left a sustainable infrastructure. We renovated the clinics at Redemption Hospital. We renovated some of the clinics at the JFK Hospital so that now they know how to handle it. It's not going to be a big surprise. So I don't think you're going to see the kind of thing that we saw a few years ago in West Africa or again in those countries.
You mentioned the Chinese. Are the Chinese, every time there's an outbreak, or are they there with us to try to fight these outbreaks?
Yeah, they're smart. They get good PR and they get good relationships that they develop. They were in there just like everybody else.
Russians? Do you see the Russians?
Not so much. Not so much. The Chinese more than the Russians. But it depends on what the disease is and where it is.
Israel?
Israel sometimes, yeah, sometimes. But mostly it's the United States, the Brits, French. The French go in because they have, for example, they have historical connections to Guinea and Sierra Leone. The Brits also in Sierra Leone, they were there. So we had good collaborations with them.
You've spoken about how the United States is very much involved, and other nations as well as all over the world, with global health, whether it be Africa or Asia or wherever the problem is. And we do so because we're good, generous people, but we want to help others, but also we want to be ready for it if it hits here, and sometimes it's just an airplane ride away from here. How is the United States, the taxpayers, Congress, are we devoting the funds we need to do the research?
Yes, we're devoting a considerable amount to research, for example, in infectious diseases. So my institute, the National Institute of Allergy and Infectious Disease, is the second largest institute at the NIH. We have a budget of over $5 billion. The NIH budget total is $37 billion. And even though infections as such are not nearly quantitatively as important with regard to mortality in the United States as heart disease, cancer, diabetes, etc., we still have a major investment. And whenever there is an outbreak, what the Congress does, usually with the cooperation in a bipartisan way, no matter what administration it is, to come in and either give supplemental funds or emergency funds. And we've seen that. When we had the H5N1 bird flu that never turned into a pandemic, but it was really a threat to be a pandemic. That was during the Bush administration. That between $5 and $7 billion was invested to develop a better way to respond to pandemic influenza. When we had Ebola, there were supplemental funds that came in to fund what we did with Ebola. With Zika, the same thing. It was $1.1 billion to respond to Zika. And Zika was a South American Caribbean problem. It certainly had a problem with Puerto Rico, and Puerto Rico is part of the United States. But we did that in the same way we always do. We feel a moral responsibility that when there are outbreaks that we can help to do something about, we do it. And you're absolutely correct. It's a combination of we have altruistic responses to this. We feel a moral obligation. We also have enlightened self-interest that we want to make sure that we're protecting ourselves, but also we live in a global community. And globally, we're economically connected. We're connected by security. So it isn't like it was, 50, 60, 70 years ago. What happened someplace else is of interest to us from a number of standpoints, including security and economics. So we think globally because infectious diseases are global diseases.
Cholera is something that I don't think we see here in the United States. And I saw it in Haiti. The peacekeepers tracked it into Haiti. And we hear there are outbreaks in Yemen.
Right.
And even I was in a refugee camp recently in Bangladesh, the Rohingyas, and the monsoon season's coming, the rain season's coming, and they've got, the water's filthy, right. Absolutely filthy, right. And they're living on top of each other. Sanitation is terrible. What about cholera? Yeah,
cholera is a very important public health problem globally. Historically, there have been, now we're in our 7th epidemic of cholera. Specifically, Yemen is suffering terribly from cholera. Cholera is a disease that follows disruption of society. If you have civil unrest, wars, natural disasters like earthquakes in Haiti, followed by cholera there, cholera in Yemen with civil unrest, poverty, when you have natural disasters, when you have floods as in Bangladesh, that's when you get cholera. It's a pure public health risk. Under the right circumstances, you can eminently treat cholera because years ago, oral rehydration regimens were developed that if you can get the fluid into someone quickly enough, they're fine. If they're really seriously dehydrated, you get an intravenous in and they could be okay. However, if you don't have the healthcare infrastructure to respond rapidly to replenish the fluid, that's when you get the mortality that's associated with cholera. So there are over 1 million cases, of cholera a year at least, and there are anywhere from 20 to over 100,000 deaths, depending upon whether you're having an outbreak this particular year or where the outbreak is.
All right, well, let me ask you about cholera and focus on Haiti. When I was there and going through these cholera clinics and seeing people, and it's a terrible, terrible disease or death from cholera, is that I was told two things. One is we've got to get the supplies there. And so the question is, do we have the supplies to stockpile? And two, you've got to be able to get the supplies in. And at least there were reports that Haiti was making it a little bit hard to get supplies in from the United States. And I imagine it's very difficult to get it into Yemen right now.
Right. Well, I don't think they were deliberately making it hard to get the supplies in. It's just that the infrastructure there, particularly following the earthquake, was a mess. So it was very tough. In a place like Yemen, which is so much unrest in Yemen, to get a steady supply of material, particularly the kits that are the rehydration or rehydration kits, has been very difficult. And that's the reason why it's such a sad and tragic situation which is going on in Yemen. So many people suffering from a major, major outbreak of cholera.
Well, there's so many areas around the world, too, that are subject to these terrible disasters. You've got the earthquake zone. We've got earthquakes in Pakistan, for instance. These earthquakes are happening in multiple places around the world, and we do get disease associated with it.
Right, exactly. Disease follows natural disaster. Disease follows civil unrest like wars. So when you have man-made disruptions, which are civil unrest and wars, and natural disruptions, which are floods, earthquakes, hurricanes, that's when you wind up getting infectious diseases that come in.
Do we have any level of cooperation in the World Health Community with Iran?
Unofficially, Iran has some really good scientists. Unfortunately, they're not as free to be able to go around. They come to some of our meetings, and I think that as a culture, they historically were very good and are in the sciences and in medicine.
But do they have outbreaks? I don't read about them having outbreaks. I imagine that they do, and I just don't see it.
Well, I don't think they have any less or more than we do. I mean, when influenza goes worldwide, you're not safe because you're in Iran. You're not safe because you're anywhere. You can't keep out the rest of the world, particularly respiratory outbreaks. That's one of the reasons why when one says that if there's an infection or an outbreak in one country of the world and it's a respiratory-borne illness that can be easily spread, it'll spread throughout the world. It doesn't matter what your political assuasion is.
But when we have those risks, do we ever hear from Iran, like, about our stockpiles? Do they want help? I mean, any word at all?
I don't think I could comment on them, Greta. I'm not sure.
How about North Korea?
I don't have very little interaction with them.
So if they get some influenza, they don't ask us for help?
They may be able to handle it themselves. I mean, I don't know what the situation is with regard to vaccines there. I wouldn't be able to comment intelligently on it.
Well, there's not much travel back and forth, so I guess that risk is somewhat eliminated by the fact that they are hermetically sealed from the world and don't participate. Right. AIDS. AIDS. When you hear Dr. Fauci, you think the word AIDS. You've spent an awful lot of time working on where are we now in fighting that?
It's an interesting situation. The scientific advances over the last couple of decades have been nothing short of breathtaking, particularly in the arena of treatment. So we have a very interesting situation with AIDS. AIDS is still a major global health problem. There are 36 million people living with HIV. 35 million people have already died. There are 1.8 million new infections a year and 1 million deaths per year.
Mostly where?
Yeah, mostly in the developing world. 90% of the infections are in the developing world. 67% of them are in sub-Saharan Africa. But we still have a problem in the United States. There are 1.2 million people in the United States living with HIV. We have, about 30 to 40, close to 40,000 new infections each year. The demography has changed. It's mostly focused on African American gay men. I mean, African Americans comprise 12% of our population, yet close to 50% of the new infections are among African Americans, mostly African American men who have sex with men. So the problem is there. But if you look at the tools we have, it's extraordinary. So we have treatments now that with a single pill, if you can give it to a person, it would bring the level of virus to below detectable level. So that's really good because you save the person's life. Number two, when the virus goes below a certain level, it becomes almost impossible for that person to infect someone else. So theoretically, although practically this is tough, but theoretically, if you could identify everyone who is HIV infected and put them on therapy and get their viral load to below detectable level, you could turn off the entire HIV epidemic. However, we have an implementation gap. We have the tools of treatment. We have pre-exposure prophylaxis. If you give a single pill a day to someone who's not infected, that you could protect them from acquiring infection. What we need to do right now is we need to be able to implement that and get into those regions of the country in the United States, such as the southeastern part of the country, where is now the focus of HIV, or to certain countries such as sub-Saharan Africa and Eastern Europe, where you have most of the cases. If we could do that, we'd have a major direction of essentially bringing the epidemic down.
All right, tell me, what is it if you get that diagnosis of AIDS or HIV in Africa versus you get it here in the United States? What's the differential in terms of life expectancy, in terms of treatment, costs?
If you're in Africa, well, first of all, what we have in Africa and the developing world, we have two things. One is the Global Fund to fight HIV, AIDS, tuberculosis, and malaria, but importantly, we have PEPFAR. So PEPFAR was a program that George W. Bush, President Bush, started, which has now saved, 13 million lives have been saved by people who are on therapy now. that would not be. So you asked the question, if you're in Africa or in the United States and you get HIV, if you're in Africa and you're in a program like PEPFAR and you get drug, you can do just as well as somebody in Washington, D.C. or New York or San Francisco, because the drugs work. The question is, we've got to get the drugs to the people who need it. And now more than 50% of the people in the world who are infected are actually on drugs. We've got to implement it more. That costs a lot of money. The thing that will put the nail in the coffin of HIV/AIDS is when we develop an HIV vaccine, which we are, it's not easy because HIV is a very different virus than anything else. The body does not make a very good immune response to it, so it's very difficult to get a vaccine. But even if we got a vaccine that was 50 to 60% effective, when you combine that with treatment as prevention, pre-exposure prophylaxis, and interestingly, a procedure like circumcision itself can provide a 60 to 65% protection against infection. So if you put them all together, we refer to them as combination prevention. Treatment, prophylaxis, circumcision, change of behavior, condom use. We believe we can turn around the epidemic. It becomes an implementation issue as opposed to a scientific issue.
You mentioned smallpox, saying we've eradicated.
Yeah.
Many of us fear smallpox. That there could be an epidemic on it, whether used as a weapon almost. We have smallpox here in the United States. I don't expect us to use it, of course. And where else is smallpox in the world?
Well, the two places in the world that have the only supply that we know of is the United States and Russia. And that was an agreement made when the stocks that were held were destroyed, we hope. And two countries had a reference strains so that you were able to work with them. But we have now, in response to the biodefense effort that I mentioned that really started in earnest following the anthrax attacks, we realized that we only had about 15 to 18 million doses of smallpox vaccine in our stockpile. So we invested a lot of money to be able to increase that to hundreds of millions of doses.
That's what we have.
Well, we have, right, exactly. So if there is
we have 300 million people in the country.
Right. But you don't need to vaccinate everybody with smallpox, because smallpox is interesting. There's a thing called ring vaccination, and that's how we eliminated and eradicated smallpox. Because if you get an outbreak of an index case here, and you vaccinate the people who are the contacts of the person and the contacts of the contacts, you have time, because unlike other vaccines, if I get exposed to smallpox today, I could wait several days and get vaccinated, and my vaccine will protect me from getting sick, because smallpox takes several days before you get sick. So it isn't like 1 or 2 days after you get exposed, you have smallpox. So we have that grace period to be able to vaccinate people. That's the reason why this ring vaccination approach works, where you sort of vaccinate people around that person who was infected.
It seems that there's so many people in the world wanting to help and to stop these viruses and stop influenza and treat and research. But there's a part of me that wonders, there's a lot of trust in terms of people don't go rogue. Whether it's with smallpox or anthrax. Right. The trust factor is an important element in this.
Well, it's more complicated than just trust. Trust is important, but what we've tried to do among the researchers who are in good faith working in the field is to create what we call a culture of responsibility, meaning you don't do anything reckless. You don't do an experiment that might accidentally go awry. When you do experiments with agents that could be dangerous to the community, you do it under the appropriate containment facilities, and that's the reason why we've built those around.
That's the good motive ones.
Yeah, that's the good motive ones, but there are bad guys, and the bad guys are going to be bad guys no matter what you do. You can't convince the bad guys not to do something bad. You just have to try and be prepared for it by developing the kinds of countermeasures that you could diagnose, identify, treat, and prevent when someone does go rogue. And as you can see, although we always want to be prepared and the threat is there, we've done pretty well about not having any of these rogue outbreaks. The only one that we really had in our country was anthrax, and that turned out to be a homegrown terrorist right here, not a state-sponsored or a foreign terrorist.
What about the former spy from Russia who was, something happened to him in Britain?
Right.
And you've got Kim Jong-un's half-brother in Malaysia.
Right. So those are individual attacks against an individual person. So obviously, the Russians were making this Novichok type of a compound that could damage you and kill you pretty quickly. Interestingly, that the daughter survived and is out of the hospital, and the father seems to be at least getting better and better. But that's not an attack on a society.
Does that just spread one-to-one? I mean, where you
yeah.
one-to-one, you can spread it to one person, but you don't walk through Times Square and spread it to everybody.
No, you see, that's the point. That's the thing where you have to gauge the kinds of preparedness. Now, if someone wanted to take this gas or this toxin and put it into a ventilation system, the people who were exposed would be severely damaged and many would be killed. But if I got it myself and you didn't, I couldn't give it to you. That's different than an influenza type thing where we spread it among each other.
What about Legionnaires' disease?
Well,
the old deal, was the Legionnaires' disease, was that an accidental, or how is that spread?
Well, Legionnaires is all around. I mean,
don't fear Legionnaires, right?
Well, it happens. The bacteria gets into these water supplies, these water tanks. Remember what happened in New York City just a couple of years ago? And then what happens is that they get sort of aerosolized. People breathe them in, and you get Legionnaires type pneumonia. But that's not something that you would expect is going to be a problem vis-a-vis bioterror.
Do we need to have attention on climate? Whether it's mosquitoes wanting to go migrate someplace with dengue or Zika, or even birds migrating with water supplies. I mean, to what part does climate play in this?
It plays some. I think probably the thing that's the most obvious when you think of this issue of warmer temperatures, which we know from what we're seeing, which is happening at the ice caps that they're melting. So the temperature is warmer by a slight amount. The thing that's most obviously influenced in the infectious disease world is the range of vectors like mosquitoes and ticks and others, that they don't winter out as long. So if you have a moderate climate in which it gets really cold at this particular time and the temperature changes a bit, you may have an extra few weeks to a month. You can extend the season where these vectors spread disease. Also at different elevations. Mosquitoes don't do very well above a certain elevation. If it gets a bit warmer, then there will be mosquito activity in areas where there were not mosquito activity.
But bottom line is you're watching everything for us.
Absolutely.
The NIH is watching everything.
We're watching, Greta.
And the taxpayers here are helping, and we're looking out for the world.
The CDC is watching, the NIH is watching, a lot of groups are watching.
Dr. Fauci, thank you very much.
It's always a pleasure, Greta.
Nice to see you.
Same here.